Hi.
Hi.
I'm realizing that the PowerPoint that I don't know where that PowerPoint came from, but the one that was for tonight is not right. It's only got 2 pages to it. And so I could use one from another semester, but I think I made some changes to it before the semester started. And so I'm going to go onto my other computer and download it.
What? That's okay. I'm recording in progress.
done right.
So I'm realizing I just got on to see what the PowerPoint, to review the PowerPoint, and realized that it's the wrong PowerPoint. And so I could take it from another class that I taught last semester, but I made some adjustments to it before the semester started. And I prefer to use the one that I adjusted. So give me 1 second just to re-download another one. So if you didn't hear what happened, so I got on to review the PowerPoint before class started and realized that it was the wrong PowerPoint. And so I just re-uploaded another PowerPoint. We'll see if it's there. Hopefully it's the right one. We'll figure it out here in a second.
Alina, come eat, honey.
Not that one. Okay. So yeah, I apologize about that. I got on there and realized that it was only 2 slides. And I thought, well, that isn't gonna work. First, are there any questions or concerns? As always, I've got one person that I can see their face. If you'd be willing to turn on your cameras, I'd really appreciate it. I think it only lets me see like 5 people at a time anyway, including myself. So we're really 4 people. Is it 4? It's 5 people, as I can't count. So I know more of you have it on, but it randomly shows me certain people. So tonight, spinal cord, spinal nerves, and somatic reflexes. Spinal cord injuries in the US. So a student asked me the other night how much we talk about spinal cord injuries. Not very much, because I don't know a whole lot about it. What I know is that most of the time it's irreparable. Because as we talked about in the nervous tissue, these, when it's happening in the central nervous system, more often than not, it's permanent. So the spinal cord is this information highway that connects the brain with the lower body. This is just showing the causes of, average percentage wise, of different spinal cord injuries. As you can see, most of them are coming from accident working, a motor vehicle accident. However, thousands of Americans are paralyzed by spinal cord injury every year, with devastating effects on their quality of life. Different functions of the spinal cord: conduction. Nerve fibers conduct sensory and motor information up and down the spinal cord. Additionally, we have neural integration. Spinal neurons are receiving input from multiple sources, integrating it and executing it appropriate output. This is kind of what we talked about the other night with regards to one neuron receiving multiple inputs and deciding what to do, if any, with regards to the stimulus that's coming in. Locomotion. The spinal cord contains central pattern generators, groups of neurons that are going to coordinate repetitive sequences of contractions for walking. Reflexes, involuntary responses to stimuli that are vital for posture, coordination, and protection. So even when you're not getting specifically your reflexes tested, you're still have constant reflexes occurring. For example, keeping you upright, allowing you to watch an object as it moves, or allowing you to watch an object, like when you're driving, allowing you to watch an object as you continue to move. Spinal cord is a cylinder of nervous tissue that's going to arise from the brain stem at the foramen magnum of the skull. Remember, it's got 31 pairs, and we've got a series of plexuses: the cervical spinal plexuses, the thoracic spinal plexus, the lumbar, and the sacral. And one coccygeal nerve coming off a coccygeal plexus. Within the within the spinal cord, there's about 100 million neurons with 50 times more neuroglia. It extends from the medulla oblongata to the conus medullaris. Spinal cord injuries commonly result from fractures of the C5 to C6, but very rarely from L3 to L5. Remember when we're talking about C7, 1 through C7, T1 through T12, or we're looking at the level of the vertebrae. And that's going to tell us at what level of the spinal cord we're at. So injuries tend to occur between C5 and C6, but never at L3 to L5. Why? Any ideas? Any suggestions?
I would think that because the C5 to C6, because it's in your neck here. So
Yeah,
like flash and anything like that.
it's a very vulnerable spot.
Mm-hmm.
And when you think about, flexibility wise, where do you tend to be more where do you tend to be most flexible?
Right, and that C4, 5, 6 area.
Yeah, there isn't an answer for this, so that's what I would think too. So it occupies the upper 2/3 of the vertebral canal, because the vertebral column grows faster than the spinal cord. And it continues to elongate after the spinal cord has stopped elongating. So it usually only extends down to L1 in adults. And it's going to give rise to 31 pairs of spinal nerves, with each part of the spinal cord being supplied by each pair of spinal nerves. And each pair is referred to as a segment. There's two, actually, I want to back up just for a second because I don't think I have a picture of this. Don't think there is. As I was telling you, I was getting onto review and realized that I haven't put it up, so I'm not sure if it's on here or not, but I don't think it is. What is it called? No, that's not it. That's it. So when we're looking at the spinal cord. So as each one of the vertebrae stacks on the next one, there's between the two of them, there's a hole that comes up out the bottom of the top one and the top of the second one. They're called the intervertebral foramina. And so like it sounds, it's going to be in between the vertebrae, and this is where each pair of the spinal nerves is going to originate off the spine and enter out to go into the peripheral nervous system. A little better drawing. When people get spinal stenosis, a lot of times what they're struggling with is compression of these, and then stenosis, meaning a narrowing of this hole, which results in pinching of that nerve. Only been within the last, I don't know, 50, 40 years that we've discovered what was causing a lot of pain for a lot of people. Didn't expect it to take me back to the beginning, but it did. So let's get there. So along the spinal cord, there's two cervical enlargements. Two enlargements, cervical enlargement, which is going to give rise to the nerves of the upper limb, and the lumbosacral enlargement that's going to give rise to the nerves of the pelvic region and the lower limbs. The cauda equina, and if you remember, I had a picture of this in a cadaver. The cauda equina gives rise to its bundle of nerve roots that occupies the vertebral canal from L2 to S5. And cauda equina meaning a horse's tail or tail of the horse. And it looks very similar to a horse's tail. It's divided into 4 regions named for the level of the vertebral column from which they arise. With one major exception, we have 8 cervical nerves and we have 7 cervical vertebrae. All of the others are matched. So we have 12 thoracic nerves, 5 lumbar nerves, 5 sacral nerves. What's going on with the cervical nerves? What do you think?
Maybe since C1 articulates with the base of the skull, there's a that's where some of the nerves come out in between the skull and C1.
You're so smart. That's right. Yes. So it's coming off above C1. All of the others are coming off underneath. But the first cervical nerve is going to come off up above C1. So divided into 4 regions. with the level of the vertebral column from which the spinal nerves arise. 8 cervical nerves controls the sensory and motor activity of the head, the neck, the upper body, arms, and hands. The thoracic nerves control the sensory and motor activity of the hands, fingers, chest, and abdominal muscles. The lumbar nerves controlling the sensory and motor activity of the hips, knees, ankles, and toe muscles. And sacral nerves controlling the sensory motor activity of the legs, toes, bladder, and anal muscles, and then 1 pair of coccygeal nerves. Since we know that nervous tissue is delicate and it requires protection, so we've got the first level of protection is a lot of bone. So the vertebrae are going to provide a strong protective defense against damaging blows. The next layer of protection is going to be the meninges. So if you remember, when we talked about meninges before, and I do remember that PowerPoint was really chaotic, but the meninges are 3 sheets that are going to surround. It's going to be a sheet wrapping around the spinal cord and the brain. And it's continuous throughout, and that's going to be really important later. Starting from the outside, the most superficial, the dura mater, the arachnoid mater, and the pia mater. Dura mater meaning hard mother. It's really, 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 really hard. It's tough. It's hard to tear. You really can't tear it. You have to cut it if you're going to do anything with it. The arachnoid mater. Remember, I asked you what if you are familiar with the movie Arachnophobia. Well, I don't like scary movies. I like graphic movies. I like violent movies sometimes, but I don't like scary. Or I did not like arachnophobia. Meaning the fear of spiders. And this looks like a spider webbing. It's a webbing that you can easily tear through, and it looks like a webbing. The pia mater is 1 to 2 layers thick. And it is being 1 to 2 layers thick, it's essentially transparent. And so when you're looking at the brain or the spinal cord, you're looking through it. Below the arachnoid mater is the subarachnoid space. This space is found in both the brain and the spinal cord. And it's filled with cerebrospinal fluid. The pia mater is collagenous with some elastic fibers and blood vessels that supply nutrients. Above the dura mater is the epidural space. This is another space that you only find in the spinal cord. So the subarachnoid space you're going to find in both the brain and the spinal cord. The epidural space is only found in the spinal cord. Epidural meaning it's above the dura mater. Subarachnoid meaning it's underneath the arachnoid mater. We have also these little denticulate ligaments. And remember, denticulate, dent meaning teeth. Why that would be called a teeth ligament, I don't know, because it doesn't look very much like teeth. But these are extensions of the pia mater that are going to suspend the spinal cord in the dura mater sheath. The epidural space is going to contain blood vessels, adipose tissue, and loose connective tissue. The subarachnoid space is going to contain the circulating cerebrospinal fluid that's going to cushion the spinal cord and deliver nutrients and eliminate waste. So right above the dura mater is this fatty pad, the epidural space. Then there we have the dura mater, the arachnoid mater, and immediately deep to the arachnoid mater is the subarachnoid space. If you're asked to be able to find them on a diagram, just start counting in. I will tell you the mnemonic that I use, and I should have said this before, the mnemonic that I use for learning these is DAP. Dura mater, DAP, D is in Delta, A as in Alpha, P is in Papa. So dura mater, arachnoid mater, and pia mater. A lumbar puncture or a spinal tap is taking a sampling of the cerebrospinal fluid in the subarachnoid space to look for bacteria, blood, white blood cells, or any other abnormalities, or many other abnormalities. Agents such as chemotherapeutic drugs, analgesics, meaning anesthetics, or contrast media can be injected into the subarachnoid space. One thing that I'm learning from hearing about injuries and different things that go on is once this is done, when someone has one of these done, they have to stay in a fetal position for quite a while afterwards, or they get severe, nasty migraines. Why do you think that would be the case?
You're removing volume of CSF, which actually makes your brain drop a little bit in your skull.
Right. See, you guys are so smart. You already knew that. Yes. So your brain is essentially floating in this. If it wasn't present, your brain would actually slide through your foramen magnum. And so it's essentially suspended in it, like Justin said. We'll see some of this brain tissue that I have, and you'll see that it's got the texture of like cold oatmeal. An epidural injection is when the needle is inserted into the epidural space, remaining superficial to the dura mater. It's usually introduced around L1 to L2. why would it be introduced between L1 and L2?
So you're only wanting to, affect a certain, region of like the lower body or spine, correct?
Right? Why wouldn't you ever go higher?
Your heart and your lungs and whatnot, wouldn't it affect them negatively if it were higher?
I think it might, but the other reason why it wouldn't, Christina, is because that's where the spinal cord ends. So if you really don't want to run the risk of nicking the spinal cord, you wouldn't inject something above that.
Gotcha, thank you.
Yeah, I don't know if I've actually read that somewhere. That's just my logic. I know that there is a risk, and it's very, very rare that it actually can circulate up and cause paralysis. I've probably only heard of that happening in 1 or 2 cases though. So if you remember the white and the gray matter and the white, or excuse me, the white and the gray matter in the spinal cord is exactly the opposite to that of the brain. In the brain, the gray matter is the outer surface, and the white matter is the internal surface. In the case of the spinal cord, the white matter is on the outer surface, and the gray matter is internal. So the central area of the gray matter is shaped like a butterfly, surrounded by white matter in the 3 funiculi. One thing you'll see is that it looks it looks like what it, I think the neatest thing for me is when I'm looking at a cross section through a spinal cord is it looks like this. It's almost perfectly shaped like this. But the white matter is arranged into 3 funiculi, or as I think your lab book like to call them, columns. The gray matter, remember that gray matter is neuron cell bodies with synapses and dendrites. It's very little myelin, that's why it looks gray. The white matter is highly myelinated. So the gray matter is a site of information processing and synaptic integration. And the white matter is going to carry the signals from one part of the central nervous system to another. So it's going to contain the bundles of axons, the funiculi, that are going to carry signals from one level of the central nervous system to another. And these bundles are tracks. The spinal cord has a central core of gray matter with a pair of posterior dorsal horns, which are carrying this posterior root of the sensory fibers. Remember, sensory fibers are coming in the back. Motor fibers are exiting the anterior side. So the posterior dorsal horns are carrying the posterior root of the sensory fibers and have the cell bodies of the interneurons. The anterior horns are carrying the anterior root of spinal nerves carrying the motor fibers. So afferent coming in the back, efferent. Remember those terms from before. Afferent meaning incoming, efferent meaning exiting. Another way to think of afferent is arriving. The gray commissure is the connection between the two halves. And it's got a central canal that's lined with ependymal cells. Do you remember what were ependymal cells?
They are neuroglia that produce the CSF.
Correct, good job, yes. One thing that I learned, I'm always learning new things. But this last semester, I had students that were, we'll dissect one on, I'll try to get it done. We'll work on it, get it done in lab on Wednesday. But I have a fixed brain and it looks black in places that are lined with ependymal cells. And I only figured out what the black stuff was last semester, because I can tell you that I don't know a lot about sheep anatomy, and it's really, really small. And my students were asking me, well, why is it all dark? And I said, you know, I don't know. And I thought about it for a little bit. And when you see clotted blood or dried blood, what color is it? For any time, go ahead, say it again, I'm sorry.
Very dark, almost like a dark red black.
Yeah. And I thought, well, guess what? Where's the cerebrospinal fluid coming from? It's coming from the blood. And so when we were looking at the ventricles of the brain, which we'll see, when we were looking at the ventricles of the brain, well, guess what we were looking at? We're looking at clotted fixed blood. And I thought that was really interesting. So if you were able to see this and it wasn't shrunken in and collapsed in on itself, which most likely it would, you would see that it's lined with what looks like clotted blood, because the ependymal cells are constantly secreting. The lateral horn is visible from T2, so the thoracic vertebrae 2 through L1. And it contains the cell bodies of motor neurons. This is going to be important when we talk about the autonomic nervous system. This is why you only see it there, is because we're going to have a sympathetic chain. If we were looking at the spinal cord, and I'm sorry, I'm going to shift back because I want you to remember this when we see it again. If we're looking at the spinal cord from about T1 to L2, T1 right approximately, T2 to L1, I'm sorry, T2 to L1, right here to L1, there's what's called the sympathetic chain ganglion. And it goes, it looks like a little chain that's going to go right next to the vertebrae on both sides. Actually, I think it's only on one side. And that's where the sympathetic nervous system cell bodies are. That's also why you only see the lateral horn through this area. So one of the questions that may come up later is, why do you only see the lateral horn here? In this area from T2 to L1. Every time I teach this, I make connections in my head that I didn't have before. And I also realize how little I actually know, because the more we learn about the nervous system, the more we recognize how little we know. White matter surrounds the gray matter, and it's got bundles of axons that go up and down the spinal cord, allowing for communication between the different levels of the central nervous system. The bundles are arranged into 3 pairs of funiculi or columns. The posterior funiculi, the lateral funiculi, and the anterior funiculi. Subdivisions within each of these funiculi are called tracts or fasciculi. We'll see the word fasciculi, I think, again. So you've got ascending tracts and descending tracts. You've got information that's coming from the brain down the spinal cord. And you've got information coming from the peripheral nervous system into the spinal cord and up to the brain. There's lots of tracts. If you start going into your textbook, you're going to see that there's lots and lots and lots of tracts. We only want you to learn a few of them and learn about a few of them. So learn about the ones that are listed here and don't worry about the others. Specifically, we're going to talk about the gracilia and cunicate fasciculi, the spinocerebellar funiculi, spinothalamic, and the corticospinal. So all fibers in a given tract have the same origin, destination, and function. Think of these as being highways. The ascending tracts are going to conduct sensory nerve fibers up the spinal cord toward the brain. And the descending tracts are going to conduct motor nerve impulses down the spinal cord from the brain. Sensory and motor tracts in the spinal cord are continuous with the sensory and motor tracts in the brain. So each tract can carry specific types of information from one location to another. So if you want to carry painful information from the spinal cord to the brain, you're going to use one particular tract, the spinothalamic tract. While if you want to carry voluntary motor movement commands from the brain to the spinal cord, you're going to use the lateral corticospinal tract. And this is what was said before. You're only responsible for knowing a few of them. Not even several, it's more a few. Some tracts undergo decussation, meaning they cross at the midline. So the brain is going to sense and control contralateral sides of the body. These tracts are contralateral, meaning the origin and the destination are on opposite sides of the body. If the tracts do not decussate, they're ipsilateral, meaning the origin and destination of the tract are on the same side of the body. I think I told you about my friend's baby that is now not a baby. She's now almost 12 years old. Who sustained 2 hemorrhagic strokes right after birth. And they can tell, and I think he's gotten significantly better, but they could tell very early that different parts of his brain had been more damaged than others. And that he'd sustained more damage to one side than he had to the others, based on his ability to reach out and grab things, because it's controlled by opposite sides of the body. And he's had to work really hard on some things, for example, gaining balance. He does horse riding lessons specifically to help him work on balance and posture. So sensory impulses, these ascending tracks, are going to travel across 3 neurons from the origin, the receptors, into the sensory areas of the brain. There's first order neurons, which are going to detect stimuli and transmit that signal to the spinal cord or brainstem. There's second order neurons that are going to synapse in the spinal cord or brainstem and can move that information to the thalamus, which is in the upper part of the brainstem. And then there are third order neurons that are going to carry those signals the rest of the way to the sensory region of the cerebral cortex. So the integrating centers in the spinal cord are within the center. The integrating centers within the brain are on the surface. And I'll ask you in the next chapter why that would be maybe so important. The gracilis or caniculate fasciculi, or gracilium caniculate fasciculi, convey sensory information for discriminative touch, light pressure, and conscious proprioception. What in the world is proprioception? Justin, are you asking your friend? I know you are. I saw that and I thought he knows. He knows. What's proprioception? Justin, you can't answer. What's proprioception?
You won't tell me anyway.
You won't tell me? Well, that isn't very nice.
He just says, I know. And I'm like, what is it? He goes, you'll find out.
A lot. Proprioception is being able to sense the positions and the locations of your joints without being able to see them. So being able to sense, if you, for one idea, being able to sense that you were falling with your eyes closed. Being able to close your eyes and have someone shift your joints around and you be able to tell them where your joints are. The gracilis fasciculus is going to convey sensory information from the sacral and lumbar body areas to your brain, including your legs. The cuneate fasciculus is going to convey sensory information from the thoracic and cervical body areas to your brain. So gracilis, sacral and lumbar, caniculate, thoracic and cervical. Both of these are composed of first order nerve neurons. Remember, the first order nerve neurons are going to move from the periphery, transmitting that signal to the spinal cord or brain. And so both of the fasciculi, the gracilis and the cuneate fasciculi, are composed of first order neurons. So this proprioceptive senses are carried out by muscle spindles, muscle receptors in the joints that sense the location of those joints and send signals back. So proprioception is this non-visual sense of positions and movements of the body. Spinal thalamic tract is going to transmit sensations of pain, warmth, coolness, trickling, itching, and deep pressure, and it's found in the anterior and lateral funiculi. So posterior funiculi contains the gracilis and cuneate fasciculi. The spinal thalamic tract is contained in the anterior and lateral funiculi. And it's made of second order neuron fibers. And these decussate, so they cross over. So signals are sent to the contralateral side of the cerebral hemisphere, to the site of stimulus. Shh, shh. Louie, 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 buddy, Louie. The threat's over, we're good. Okay. Descending tracts. So we have upper motor neurons that are going to originate in the cerebral cortex or brainstem, and they're going to terminate on the lower motor neuron. The lower motor neuron is in the brainstem or spinal cord. And its axon of the lower motor neuron is going to lead out to muscles or other target organs. So ascending tracts have three orders of neurons. Descending tracts have two. One of the descending tracts is the corticospinal tract. Remember, this is carrying voluntary movement of skeletal muscles. And it's in the lateral funiculi. If your brain decides that it wants your legs to move, it sends this information via command from the brain down to the region of the spinal cord that's responsible for leg movements using this tract. Which of the following statements is true concerning the spinal thalamic tract? The spinal thalamic tract terminates in the spinal cord. The spinal thalamic tract begins in the thalamus of the brain. The spinal thalamic tract is found in the gray matter of the spinal cord. The spinal thalamic tract carries motor information down the spinal cord. Or the spinal thalamic tract is composed of multiple axons carrying information in the spinal cord. Say it one more time.
B is in Bravo.
You know what? Was that it? I think you're right. I was thinking it was something else, but I think you're right. So it's second order neurons. Yeah, you're right, Christina. Good job. Because coming back up here, made of second order neurons. Good job. ALS, characterized by the progressive degeneration of motor neurons in the spinal cord, brain, and motor cerebral cortex. If you're not familiar with this person, you should be. This was Stephen Hawking, and from his adventures, we learn that there's two types of ALS. There's an early onset, and there is a late onset. And so when he was diagnosed, I think he was 22. It's 21 or 22. He was told that he had 2 years to live. And obviously that wasn't the case. But what happens is the neurotransmitter glutamate increases, and it increases to such levels that it becomes toxic. And if you're going to increase the amount of neurotransmitter in an area, what would you do to get rid of it? You would work to increase the amount of calcium to stimulate exocytosis of it, right? If you're not sure, just say yes, because this is my theory. I honestly, the most that I read about ALS was your book, and I thought I had it figured out and realized that I didn't. There were some errors in my hypothesis of how this would work. But eventually what it does is it damages the dendrites, resulting in death of the dendrites. So if you destroy the input part of the neurons, you're no longer going to make, those neurons are no longer going to be functioning. Any questions so far? We're moving through this really fast tonight. We'll probably start the next chapter also if we continue at this rate. Let's see what happens. Yeah. The spinal cord is going to communicate with the rest of the body by way of the spinal nerves. And each nerve is a cord-like axon composed of nerve fibers bound together by connective tissue. The most outer layer around the nerve is the epineuron. Remember, epi is always on top, so it's going to be the most outer layer. Like that, the epidural space. Epineuron is going to be on the most outer layer. We're going to see this again. Try to remember these relationships between these terms. Epi always means on top. Neurium is the outer sheath. The perineurium is going to surround each bundle of axons. We can have nerves that just carry sensor information. We can have nerves that just carry, bear with me, let me say this a different way. Each bundle is called a fascicle. Fascicles can carry motor information by themselves, sensory information, or both. Around the myelin of the neural lemma, remember that's the most outer layer around the myelin, is a sheath of endoneurium. So epineurium covers the outer cord. Perineurium surrounds the fascicles. Endoneurium is going to surround each myelinated axon. So endoneurium, loose connective tissue external to the neural lemma. Remember, the neural lemma is the most outer part of the myelin sheath. The perineurium are layers of overlapping squamous cells that are going to wrap the fascicles, bundles of nerve fibers. And the epineurium is dense, irregular connective tissue that wraps the entire nerve. You guys, are there any questions? We're going fairly fast. Are there any questions?
No. I did talk to that patient, that's the neuropsychologist, and
Yeah.
he did answer those questions that you wanted me to ask him. So
Let
I
me,
guess some of it. Huh?
yeah, let me ask you, what did I want you to ask him? Shoot.
It was about the neurotransmitters and the, what was it? And damage to the occipital complex.
Okay, what did he
cortex.
say? What did he say?
And schizophrenia, and he also mentioned schizophrenia. So he said that schizophrenia is just basically the neurotransmitters being overactive.
Okay, what did he say about the occipital lobe and schizophrenia?
He said that that doesn't really affect schizophrenia. It depends on, like he said, schizophrenia and like it's just basically the transmitters being overreactive in the receptors.
Okay.
And then I also asked him about like ADD and ADHD, and he said with those diseases, it's the receptors not getting enough oomph. I don't know. I don't know.
They're not getting enough neurotransmitter.
Yeah, they're not getting enough neurotransmitters. So that's why with Ritalin and the other medications you take for ADD, ADHD, those medications help create those neurotransmitters.
So let me back up with what he said. So Lauren has someone who she works with in dialysis, who is a neuropsychologist. He's a retired neuropsychologist. And I asked her, because I have a good friend who deals with pseudo-schizophrenic tendencies, and we're pretty sure she has damage to her occipital lobe because of that Chiari malformation that I mentioned at one point. I'm still not sure I completely agree with him. I think I'd have to do my own research with that, because I know that's where that information is processed.
Like he's been out of practice for like 25, 30 years. So like he's speaking off of he was just speaking off of what he knew from the, I mean, he still reads like the journals,
I believe
but
him.
it's not like before. Like he's in active practice where he's
Right.
keeping up with everything. So
Well, and I agree with him. I agree with him on a lot of levels. I wish I understood more about what she dealt with and where it came from. What she deals with and where it comes from. But that makes sense what he was saying about the neurotransmitters and drugs, because do you remember that I mentioned in chapter 12, and it said that most drugs work on the neurotransmitters. They mimic them, or they keep them around in the synaptic cleft longer, because usually people who have some sort of psychological, emotional, mental issues, it's about the neurotransmitters. And so if you can keep those around longer, a lot of times either the receptor is being degenerated, or for some reason they're not getting enough. For example, Prozac is a serotonin inhibitor. Excuse me, Prozac is an inhibitor of serotonin reuptake. So if you can keep it around longer, people will do a lot better. Another example, and I'm trying to remember, I hopefully will see it. I think we're going to see it. Parkinson's is all right. I think it's in the next chapter, and I'm not gonna try to guess what it was, because I don't want to be wrong. But thank you, Lauren. I appreciate that. So different types of nerves: sensory afferent nerves, carrying signals from the sensory receptors to the central nervous system. Motor efferent nerves, carrying signals from the central nervous system to motors and muscles and glands. Mixed nerves are consisting of both afferent and efferent fibers. So sensory and motor. Both sensory and motor fibers can also be described as being somatic or visceral. Remember, somatic means skin, joints, muscles. And I think bones. Visceral, meaning internal organs. All the other internal organs. General or special. Special, specifically hearing, taste, sight, smelling, taste, and general. So afferent fibers, this is just a summary. Afferent, oh, okay, good, I was right. Somatic fibers, skin, skeletal muscles, bones, and joints. Visceral fibers, blood vessels, glands, and viscera. One thing that you don't see here that we have to be careful when we talk about special senses is you'll see that you don't have touch. I don't know if you grew up thinking that your special senses included touch, but not according to your book. And I think not according to most textbooks. Is that right? It's not considered here. I don't think that's completely correct. I think it depends on where you look. Because I think it's in another textbook that I have, it's considered part of the special senses. Ganglion, a cluster of neurosomas, neural cell bodies outside of the central nervous system. Among the somas, there's bundles of nerve fibers leading into and out of the ganglion. The posterior root ganglion, which you can see, that's your enlargement on the back, is associated with afferent nerve fibers. So it contains the cell bodies of sensory nerve fibers. Bear with me, I want to see. I don't think I put it in here. One thing that I learned really recently was, why do people who have had amputations deal with phantom pains? Even though you amputate a limb, the cell body remains of that sensory fiber. And the result is that you still feel it. And I thought that was really interesting, because I'd never really thought of it that way. That's the reason they deal with what feels like phantom pains. So sensory, motor, sensory, motor. You guys, let's take 5 minutes. Let's walk away, or let's go 7 minutes and walk away for a minute and come back to right here.
I have to log off because I gotta be at work at 4 in the morning.
I have fun with that one. Okay.
Yeah.
I understand.
It's a 14-hour shift, so it's gonna be
Wow.
lovely.
I understand.
I will make sure I understand what's due this week, because I don't want to miss out. So chapter 14 is this week, is that correct?
Chapter 14. Yes.
The brain and spinal. Okay, so that's due.
No, so this is chapter 13, which we will finish tonight.
Okay.
And then we will most likely we will start chapter 14 tonight also. And so
Okay.
all of chapter 13 stuff will be due next week. You don't have anything in lab,
Okay.
but we will start covering the brain in lab.
Okay.
Does that help?
Yes, so I did the exercise 24, the special senses already.
We,
So was
we
that,
have, oh, you already did it?
yeah, I already did it. I thought it was due tonight.
Darn it, I shouldn't have opened it for you. Oh, well, okay, I'm glad you got it done. That's awesome.
Yeah, well, I think I asked you to open it because I don't want to fall behind. Okay, so pretty much, so this week,
We created it on Saturday.
oh,
Together on Saturday. So, but awesome. Okay, I'm glad you got it done.
okay, so chapter 13 is due this week.
Mhm.
It looks like chapter 14 is opening up tonight. Technically it opens up at midnight, but
I will open chapter 13. So it should actually be due. I'm sorry, I'm eating at the same time. It will actually be due next week. So
okay,
it will be due next excuse me, next Sunday night.
okay. All right, it sounds like I've got everything checked off. Cool.
Okay.
All right. Thank you.
Of course, have a good night and thank your friend for his input.
Yeah, I will. And if anything else, he's been helping me a little bit with like the nerves and everything, and he's an
is-
interesting conversationalist.
He knows. You should ask him if he ever wants to guest lecture. He knows. He knows the
Mm.
information.
He's not really tech savvy. He's
Well,
like in his
he
80s.
doesn't, we could show him. He knows. He's got this down. And it would be
All
really
right, well,
interesting to get his input.
I'll bring it up to him to see if he's interested in it. But
Yeah.
I mean, it is what it is. But I'm gonna log
Yeah.
off for the night. Have a good night and see you
You
Wednesday.
too. You too.
Bye.
My body. Come here. Come here. Come here, Louie. Come here, buddy. Hi. What are you doing? What? What? Come on over here. Come here. All right.
How's the puppy doing?
He's really awesome. We almost lost him over the weekend.
What?
I know it was terrible. Here, let's see if you can see. Can you see him?
Oh, yeah.
Yeah, you're a sweet boy, aren't you? He slowly decided that I could be his friend too. My mom isn't his only friend at this point, most likely. But we don't have a fence. We have a little, like a probably 50 by 30 backyard. And we don't have a fence. We're probably going to invest in an electric fence. But he got out. She came in to grab something and went out and he was gone. And I got on my bike and started searching. This was Saturday. And I got on my bike and started searching for him. And of course, you know, that he's big and he can run fast. And so I thought, I have no idea where he would have gone. And I started, you know, looking out, but I kind of knew I was looking for a needle in the haystack. And I knew I was going to be better off on my bike looking for him than I would be in my car, because I'd have to be watching for other cars.
Mhm.
You can get in an accident on a bike, but not to not as easily. And it's great because we have really great neighbors. Because I started walking and calling out his name, and one of our neighbors who lives 4 houses down, she came out and she said, who are you looking for? And I told her, and she said, my daughter and I will go out and start looking for him also.
Oh, that was nice of them.
It was really nice because I guess he was out on one of the roads around here, and some people in a car stopped and made it their mission that they weren't going to allow him to get hit by a car. And
Oh,
so they stopped, and the neighbors came up, and then our other neighbor who lives right next door asked, the one set of neighbors asked him, do you know this dog? And he's like, yes. And so between the daughter and the mother and the other neighbor and this people who stopped because they didn't want this dog to get hit by a car, they came and grabbed my mom and got my mom, who was in calling the police and putting his name into a database. And she went out and called him 3 times and he came. Yeah, he's a very smart boy. He's been worked with really, really well. We realized as of today, he doesn't have any vaccinations.
oh, wow.
He's got 1 distemper vaccination, but he doesn't have anything else.
Well, he's not quite a year old, you said, right?
No, he's only 8 months.
Yeah.
But one of the worst things for a puppy is parvo.
Oh, yeah.
And so we're going to, my mom's gonna jump on it, and I'll cover the bills. She's the one who runs all the errands. She's the one who went out to Gettysburg to get his medical records.
Yeah.
But he's,
Well, I know with the invisible fence,
Yeah.
and I'll make this quick, with the invisible fence, to do it through like the invisible fence company, I know is pretty pricey, being that you have a smaller area. They sell, I think in like PetSmart and online, they sell the invisible fence that you can do like yourself. My mom has one, and it's just kind of like a hub that sits in your house, and you set up the distance that you want.
oh, really?
Yeah. And then, you put the collar on the dog, and if they go near that distance, they get like a warning beep, and
Okay.
then they'll get like a little vibration. And then if they hit that distance, then they get like a little shock.
I think that's what my brother has also. So, all right,
It works really good. And I mean, when she first got it, she had a big, like, 95-pound collie at the time. Now she has 2 little tiny dogs, but she really liked it.
Well, I realized, we've only had him for 3 weeks on Sunday.
Yeah.
And I realized, how quickly I've become attached to him.
Mhm.
He's quite the character. It's amazing, we have this little toy poodle, and he'll go out in the backyard and play with her. And, and it's pretty funny to watch him, but, he's jumping around and she's jumping around, and
Mhm.
he's just, he's just a sweet boy. We'll see. But yeah, I think we're gonna have to invest in an electric fence, because I'm not losing him anytime soon.
Yeah. Well,
That
good
was
luck.
pretty traumatic.
Mhm.
But yeah, he's a sweetheart. Thank you for asking.
No problem.
So posterior dorsal root horn is a sensory input. The posterior root ganglion contains the somas of the sensory neurons. There's 6 to 8 rootlets that are going to enter from the dorsal root horn into the dorsal root ganglion into the dorsal horn, or the posterior horn. The anterior ventral root is your motor output. And there's 6 to 8 rootlets that are going to exit the anterior horn and move out to form the anterior root. The posterior rami this part right here, is the branch of each spinal nerve that's going to innervate certain parts of the skin, muscles of the neck, and deep muscles of the back. And I thought it was on both sides. If you look right here, this is that sympathetic chain ganglion. So this is what's going to come, that's going to exit the spinal cord and enter. So it's going to, excuse me, it's going to exit the lateral horn and enter the sympathetic chain ganglion. They also call this the paravertebral ganglion, paravertebral because it's right next to the vertebral column. And so you're only going to see this from T2 to L1. No, yeah, T2 to L1. Right? No, it wasn't. It was T1 to L2. Yeah, T1 to L2. The anterior rami is going to give rise to the intercostal nerves, so it's only in the thoracic region. So if we're looking here, here's the posterior rami. Here's the anterior rami. Here's the posterior rami. Here's the anterior rami. Posterior, anterior. So because you know that I like cadavers and I don't think your diagrams do this a lot of justice, this is what I was saying when you're looking at a cross section through the spinal cord, that it looks very much like what you saw. Here's the posterior horns. Here's the anterior horns. Here's the epidural space. Dura mater would be right here. The arachnoid mater would be right underneath it. Posterior rami. Remember, these are your afferent neurons. Anything posterior is going to be afferent. Anterior is going to be sensory. Oh, sorry. Wait. Afferent, sensory, anterior motor. Efferent. So this area right here is where they would insert down below, because we're looking at the C7 vertebrae. But much further below is where we're going to, this is where they would inject an anesthesia in. Some more pictures. And this one in the back is kind of blurry, but I still thought it was a good picture. Here's the dorsal rootlets, or the posterior rootlets, the dorsal root ganglion. The ventral rootlets, or the anterior rootlets. Remember, dorsal and anterior are synonymous. Dorsal root ganglion. So your spinal cord, your rootlets, spinal nerve, dorsal ganglion, dorsal or posterior rami, anterior rami. So in areas other than the thoracic region, the anterior rami is going to form the plexuses, your cervical plexus, your lumbar plexus, your sacral plexus. So the anterior rami is going to form those plexuses that are going to form peripheral nerves that innervate ventral and lateral body surfaces, including structures in the body wall and limbs. The rami communicantes area right here, rami communicantes, is the branches of each spinal nerve that contains the axons related to the autonomic nervous system. So this is going to be very tightly associated with the sympathetic chain ganglion. Which, remember, ganglion is a cluster of cell bodies. So the sympathetic chain ganglion is a cluster of the sympathetic neuron cell bodies. The rami communicantes consists of a pair of rami, one white rami and one gray rami. So looking here, here was the sympathetic chain ganglion here. Here is this chain, it runs all the way down from T1 to L2. I'm getting my T2 to L1. Meningeal branch of the spinal nerve. So a branch of each spinal nerve that's going to serve the vertebrae, vertebral ligaments, blood vessels of the spinal cord, and meninges. Mom, can you call Daisha? Well, she's probably calling through Daisha's number because Daisha's calling me and I can't imagine, she never calls me. Okay, my sister-in-law, she never calls me. So I don't know why she'd be calling me. Unless it's my niece who's doing it and she's 7. A pinched nerve occurs when there's too much pressure applied to a nerve by the surrounding tissues, such as bones, cartilage, muscles, or tendons. The pressure is going to disrupt the nerve's function, causing pain, tingling, numbness, and weakness. So we talked about the ulnar nerve and how that's your funny bone nerve. And you can imagine how the pressure is going to disrupt the function. So the herniated disc in your lower spine can pinch a nerve root, causing pain that radiates down the back of your leg. For example, sciatica. A pinched median nerve in your wrist can lead to pain, numbness, weakness in your hands and fingers, or carpal tunnel syndrome. My mother just had surgery on this last week. What this is the tendons in this area get inflamed and they enlarge, and they are surrounded within this carpal retinaculum. This tendon called the carpal retinaculum, retinaculum meaning surrounding something. And within these within this underneath with these tendons under deep to this retinaculum, this ligament, or tendon, it's more tendon. Let me say tendon, use the right words. Is the median nerve. So when the tendons start to enlarge because they get irritated, they put pressure on that nerve, pinching that nerve. And that's carpal tunnel syndrome. And so what they do when they go into to try to alleviate your carpal tunnel syndrome is they make little minute tears in this ligament, this tendon. I should quit calling it a ligament. You know what? It is yeah, it is a ligament. They make small tears in this ligament to alleviate the pressure. So some people have this done multiple times. My dad's had surgery on it like 2 or 3 times. He's a computer guru and he has done this plenty of times, and so he's learned how to deal with it. So dorsal roots along the spinal cord contain blank neurons, while dorsal rami contain blank neurons.
Is it C?
That's about, I think that's, you know, this is what happens when I don't look at the diagram before, when I don't get a chance to look at it before. They're both sensory. And let me actually, I'm going to look at it just for a second and see if I can actually, wait. They're sensory and mixed. It's B. And that's just looking at the diagram here. If you look at this diagram, here's your afferent. Here's the efferent. We didn't really talk about it, but if you just look at that diagram, you see that there's both an afferent and an efferent nerve fibers there. This is why I try to look at the PowerPoints before we go over them, so I don't look like I don't know what's going on. But that's it. The ventral anterior rami form those plexuses. The intercostal or thoracic nerves are not going to enter into the plexuses, but they're going to innervate the structures they supply in the intercostal spaces. The cervical plexus, the brachial plexus, the lumbar, sacral, and coccygeal plexus. The cervical plexus is going to serve the skin muscles of the head, neck, and upper part of the shoulders and diaphragm. The phrenic nerve is going to be the major nerve that's going to arise off this plexus. It's what innervates the diaphragm. So C3, C4, C5 keep the diaphragm alive. because the phrenic nerve right here coming off C5, this is it right here. C5, C4, and C3. So when you get a break somewhere above the spine, above wherever that nerve was originating, everything is lost below. So if you get a break from C2 to C1, everything below is lost. So the cervical plexus with the phrenic nerve. Injuries to the phrenic nerve. Technology is getting better. One thing that can be done is putting in a breathing pacemaker or phrenic nerve stimulator. The phrenic nerve pacing is going to provide ventilation support for patients with chronic respiratory insufficiency. If their diaphragm and lungs and phrenic nerve have some residual function. So instead of a ventilator that's forcing air into the lungs, a phrenic pacemaker is going to enable the diaphragm to contract and allow the patient to inhale more naturally. Brachial plexus is divided into roots, trunks, divisions, cords, and nerves. Roots, trunks, cords, and nerves. It's going to supply the neck, the shoulders, and the upper limbs. The ulnar nerve is one that's coming off here. Your axillary nerve, your radial nerve, your median nerve. Median nerve is the one that's affected by carpal tunnel. Ulnar nerve is your funny bone nerve. Axillary, remember what the axillary region is, so that's going to be your armpit. The brachial plexus. Injuries to the brachial plexus, Erb's palsy, a paralysis that most often occurs as a baby's and infant's head and neck are pulled toward the same side as the shoulders pass through the birth canal. So you can imagine this is a strain pulling it from the same side. A similar injury may be observed at any age, including adults, following a traumatic fall or other trauma whereby the nerves of the plexus are violently stretched. Injury to the median nerve also results in carpal tunnel syndrome. Ulnar nerve is your largest unprotected nerve. Emerges from the brachial plexus. Like I said, it's huge and it's very vulnerable. So damage to it results in abnormal sensations in the fingers and inability to abduct. Abduct meaning to separate your finger, your middle and your little fingers. Abduct meaning to separate, adduct meaning to bring together. If you think what it means to abduct a child, you mean you take it away from their family. Adduct meaning to bring them together. The lumbar plexus is going to supply the anterior lateral abdominal wall, the external genitalia, and part of the lower limbs. The femoral nerve is the largest nerve of this plexus. Damage to it results in the inability to extend the leg and loss of sensation in the skin over the anterior medial aspect of the thigh. The sacral plexus is going to supply to the buttocks, the peritoneum, and part of the lower limbs. It's going to give rise to the sciatic nerve. If you remember, we had the greater sciatic notch and the lesser sciatic notch. The greater sciatic notch is where the spinal nerve is going to come out. We're looking at the pelvis bone markings, the greater sciatic notch. Damage to it results in sciatica, which can be due to a herniated disc, dislocated hip, or pressure from the uterus during pregnancy. If irritated, this nerve will cause hiccups.
C, Charlie, the phrenic nerve.
You're right. Good job, Elizabeth. Yes. Cutaneous innervation dermatomes. Dermatomes are specific areas of the skin that convey sensory input. Their dermatome maps are a diagram of the cutaneous areas innervated by each spinal nerve. They overlap in their edges by as much as 50%. Therefore, it may be necessary to anesthetize 3 successive nerves in order to produce total loss of a sensation in one dermatome. Knowing this map can make it possible to locate damaged regions of the spinal cord by the loss of sensation. Shingles is a really good way to be able to track what spinal nerve affects what dermatome. So shingles is an acute infection of the peripheral nerves by the herpes zoster virus, the nice little chickenpox virus. After one gets chickenpox, the virus is dormant in the dorsal root ganglion. In some people, it stays dormant forever and is kept in check by the immune system. However, if compromised, the virus can travel from the sensory nerve fibers by a fast axonal transport and cause shingles, which is a painful trail of skin discoloration and fluid-filled nerves. So along the dermatome of where the dorsal root ganglion has remained dormant, it's going to come out traveling along the axon and cause inflammation along the dermatome. Shifting gears for the last part of this, nature of reflexes. Reflexes are quick, involuntary stereotype reactions of glands or muscle to stimulation. They require stimulus. They're not spontaneous actions, but require some sort of sensory input. They're quick, and they involve few, if any, interneurons. So you remember you have monosynaptic and polysynaptic. If they're monosynaptic, there's no interneuron involved. If there's polysynaptic, there is minimal synaptic delay. Remember what that synaptic delay was. So if you have a synaptic cleft connecting two neurons in a synapse, you're going to have synaptic delay. They're involuntary, meaning they occur without intent and are difficult to suppress. They're stereotype, meaning they occur essentially the same way every time. There's a reflex has a reflex arc, which is a pathway that a nerve impulse is going to follow. So this is essentially, if you remember, we saw this before. We saw these nerve pathways where we start with a receptor that responds to a stimulus. This is the very beginning of chapter 12. We saw a sensory receptor that responds to a stimulus. It initiates an action potential. From that receptor, an afferent signal, nerve impulse, is going to pass back, enter through the dorsal root ganglion, and synapse either directly onto another motor neuron, or it's going to synapse with an interneuron. And then a signal is going to go out via a motor neuron to an effector, which is in many cases a muscle, a gland. So this is your same thing as what you saw with a feedback loop. You have a receptor that senses a change. You have an afferent signal. You have the integrating center. You have an efferent or a motor signal that goes out to an effector. It can be monosynaptic, meaning there's no interneuron. Polysynaptic, meaning there is one or more interneurons. Ipsilateral, meaning it's going to occur on the same side of the body where you sense the receptor sense the change, the action is going to occur on that same side of the body. Or contralateral, where it's the opposite. It's sensed on one side of the body and the reflex and the effect or the response occurs on the opposite side of the body. So just like you saw before, sensory receptor, sensory or afferent signal, integrating center, motor neuron or efferent neuron, effector. Testing somatic reflexes can involve skeletal muscles aiding in diagnosis of many diseases. I think there's a case study coming up that will go over some of this, but I can't remember if it's over this or the brain or both. And so I haven't posted it yet, but I will. Additional vocabulary. So monosynaptic, polysynaptic. Monosynaptic meaning reflex arcs that skip the inner neuron. So it only involves a receptor, a sensory neuron, a motor neuron, and the effector. Polysynaptic, a reflex arc that's going to include the inner neuron in between the receptor and the sensory neuron and the motor neuron and effector. Ipsilateral, meaning the stimulus comes from the one side of the body and the response occurs on that same side. Contralateral, meaning reflex arcs in which the stimulus comes from one side of the body and the response occurs on the same opposite side. Any questions so far? Couple examples. A stretch reflex or the patellar reflex. When a muscle is stretched, it fights back and contracts, helping to maintain equilibrium and posture. So you tap the patellar ligament that's connecting the patella to the anterior tibial tuberosity. And it excites nerve endings in the muscle spindle of the quadriceps femoris muscle. The signal travels back to the spinal cord via a primary afferent fiber and the dorsal root ganglion. And efferent signals in the motor nerve fiber, then, assuming that the afferent neuron synapses with the motor neuron, stimulating the quadriceps to contract, producing the knee jerk. At the same time, because if you're going to cause one muscle to contract, the opposite or the opposing muscle has to relax. So at the same time, as the quadriceps is going to be forced to contract down here, actually, quadriceps contracts up here. The hamstring muscles are going to relax. So a nerve fiber is the same nerve afferent fiber that forces the quadriceps to contract is going to send a signal to the hamstring muscles, inhibiting their contraction. So that you can flex the knee with, and the extensor, the knee extensors. This means the knee is flexed. The knee extensors are relaxed. So knee extensors are contracted while the flexors relax. Questions? That was quite complicated. So receptor spindle fibers, muscle spindle fibers are stimulated with the stretch of the tendon. It sends a signal back via the primary afferent nerve fiber, which synapses with two motor neurons, one of which is going to come out and cause the quadriceps to contract. The other one simultaneously is going to come out and inhibit the hamstrings from contracting. Any questions? This is a great one because we've all probably been there. Ever stepped on a Lego in your bare feet, you know what this feels like. Ever stepped on a nail, you know what it feels like too. The flexor, withdrawal, and cross extensor reflexes are going to demonstrate intersegmental. What does intersegmental mean? Remember that each of the spinal pairs of spinal nerves is a segment. So intersegmental meaning it's going to affect more than one segment. So it's going to trigger the contraction of the flexors and relaxation of the extensors in the same limb. This reciprocal inhibition, which we saw before right here. This was also reciprocal inhibition. One muscle is going to be stimulated to contract. The other muscle at the same time is going to be relaxed. The crossed extensor, so that you don't fall over when you step on that darn Lego, is going to result in contraction of the extensor muscles on the opposite limb from the one that's withdrawing from whatever stimulus it was. Maintaining balance so you don't fall over. Are you going to take him out? I will if you want to wait a little while.
Wait. They need to go out later anyway.
Well, okay, all right. Mom, this is why he's become my friend, is because I walked him after class. She's jealous of my friendship I'm developing with Louise. I know you are, Mom. Because I'm the one who always walks him. Not that she doesn't walk him too, but he's decided we can be friends for that reason. Any questions about this? So two things are going on. We're getting the same thing we got up here. One muscle's being stimulated to contract while the opposite action muscle, or the antagonist of that muscle, is going to be inhibited. And to prevent you from falling over, the muscles on the opposite leg are going to be stimulated to contract. Questions? So this flexor reflex is going to use an ipsilateral reflex arc, meaning it's on the same side. So this idea, this reciprocal inhibition, where one set of muscles are going to be stimulated to contract and the antagonist muscles are going to be inhibited, is occurring on the same side of the body. So that's an ipsilateral reflex. The cross extension, where the muscles on the opposite side of the body are going to be forced to contract, is going to be a contralateral. And one thing that occurs, the reason this is an intersegmental reflex, is because you're going to contract the muscles of your limbs. But at the same time, if you've ever noticed, when you contract the muscles of your limb, your hind limbs, you also contract your abdominal muscles. resulting in contraction of your abdominal muscles with this withdrawal reflex. So, which statement best describes reciprocal innervation?
B.
B is in Bravo, Justin? Yes. So relaxation of the antagonist at the same time there's contraction of the agonist. One of the last ones, and this was, I think, asked for you to do in the monosynaptic reflex virtual lab. The Babinski or plantar flexion is normal in adults if their big toe of their foot curls. If it doesn't and it fans out, that can indicate damage of the corticospinal tract. So it's normal for the outside of a baby who's over 12 months old, they should have, their toes should curl in. However, if they fan out in someone who's over 12 months, that's a sign of damage. Complete, so trauma to the spinal cord, complete severance of the spinal cord results in immediate loss of motor control below the level of the injury. Above a C4 threat poses threat of respiratory failure. Remember, because of the phrenic nerve and where it's coming off C3, C4, and C5. Paraplegia is paralysis of both lower limbs. Quadriplegia is paralysis of all four limbs. Hemiplegia is paralysis on one side of the body. And paresis is paralysis or weakness of the limbs. You guys, we went through that really fast. Are there any questions about the spinal cord? Okay. So so chapter 13, anything that the smart book assignment and the quiz will both be due next Sunday night. And we'll start chapter 14 right now. After we do the brain, that's when you'll have your second exam. So after chapter 14. So it'll cover 7. Oh, see, bear with me here. 7, 12, 13, and 14. I like to do if all of, at least the brain and the spinal cord and the nervous system, nervous tissue all together. Because a lot of what we're doing, you can see a lot of this is repetitive, some of it. And so I like to keep them grouped together. If you have issues with it, please just tell me. Feedback is always a good thing. Okay, let's jump into chapter 14. Paisley, come here, baby. Pacers, come here. Come here. Come here. Come here. So the brain and cranial nerves. The brain consists of about 3 pounds of tissue that simultaneously conducts and coordinates a variety of processes, with which no computer is presently able to compete. Its function is what's clinically associated with what it means to be alive or dead. All of these functions and many others are going to occur within the 85 billion neurons and 10 to 50 trillion neuroglia that compose the human brain. As a human embryo develops, the neural tube is going to form 3 anterior bulges. The prosencephalon, or the forebrain, the mesencephalon, the midbrain, the rhombencephalon, which is the hindbrain. Pro meaning in front, meson meaning in the middle, and rhomben is another word for behind, so the hindbrain. Encephalization describes the process by which the prosencephalon and the rhombencephalon are going to divide further to form 5 secondary vesicles. One of those vesicles, the telencephalon, that's going to is going to be part of the prosencephalon, developing prosencephalon, is going to form the cerebral hemispheres. What's amazing is if you look at comparative anatomy, this picture, which is a developing human, is the same thing as what you see for a puppy or a mouse or a fish. It's the same structure overall. So I did this like, I think a semester ago. And what this is showing is this is a diagram showing the 3 initial primary vesicles, the secondary brain vesicles that they will become, and ultimately the structures they become. Get a really good grasp on this chart. So the prosencephalon, that first primary vesicle is going to become the telencephalon and the diencephalon. The telencephalon is going to develop into the cerebral hemispheres. The diencephalon, which is going to develop into the thalamus, the hypothalamus, and the epithalamus. The epithalamus is going to contain the pineal gland, which is going to secrete melatonin for your circadian 24-hour rhythms. Your mesencephalon is going to form some midbrain structures, meaning the corpora quadrumina, the inferior and superior colliculi, the cerebral peduncles, the cerebral aqueduct, and the substantia nigra. Substantia nigra is the part of the brain most affected by Parkinson's disease. Cerebral aqueduct is a major place where cerebral spinal fluid is going to flow. The rhombencephalon is going to develop into the metencephalon and the myelencephalon. The metencephalon is going to develop into the pons, part of the brainstem, and the cerebellum. The myelencephalon will become the medulla oblongata. So during the first 2 to 3 months of embryonic development, there's going to be a massive, expansive growth of the telencephalon. And it's going to cause the outer portion of the cortex of the cerebrum to extend over much of the rest of the brain, enclosing the rest within the interior. So it expands out. The brain is going to grow at this amazing rate where as much as 50,000 neurons are going to be added per second. Yeah, Justin, if you ever wondered why that little girl is so smart, this is why. Same thing for Zena's kids. They're the only ones I've seen so far. At birth, almost all of the neurons of the brain will already be present. So the telencephalon, coming back up here, the telencephalon, this part right here is going to form this major expansion where it's going to essentially envelope and enfold the rest of it. And as it continues to expand, it's going to you're going to create a lot more surface area than you have space for. You know, if you consider a balloon, the reason we have as many folds as we have on our brain is because that you can't keep it. It goes like this, but then you start making folds because it's expanding so fast. So it's going to start folding and making folds. Any questions so far? The gray matter has this dull color due to the very few myelin, the little myelin that's there. It's going to form the surface layer, the cortex over the cerebellum and the cerebrum. And just like we saw in the spinal cord, it's going to be composed of neurosomas, the cell bodies, the dendrites, and synapses. And it's going to form nuclei deep within the brain. You guys remember what the nuclei are when we're referring to the central nervous system. The nuclei are the same thing as ganglia in the peripheral nervous system, clusters of cell bodies. So just like we saw with the ganglia in the peripheral nervous system, like the dorsal root ganglion, what we're looking at when we talk about nuclei here is we're looking at clusters of cell bodies. The white matter is deep to the gray matter, and it's pearly white because of the myelin. And just like we saw in the spinal cord, it's going to be composed of tracts. The cerebrum is about 83% of the brain volume. The cerebellum contains about 50% of the neurons as that found in the cerebrum, and it's the second largest brain region. The diencephalon, remember this consists of the epithalamus, the thalamus, and the hypothalamus. And the brainstem, which is the midbrain, the pons, and the medulla oblongata. Remember, the pons and the medulla oblongata are coming from the rhombencephalon. If the telencephalon was removed from a 5-week embryo, which of the following structures would fail to develop in the fetus?
Did A?
Yes, A, the cerebral hemispheres, yes. So the brain is protected by the cranial bones and the meninges. Just like we saw in the spinal cord, we have the dura mater, the arachnoid mater, and the pia mater. They're continuous with the spinal meninges. And apart from protection, they provide a structural framework for arteries and veins that service the brain. One thing that makes the dura mater and the cranial mater, in the cranium different from the dura mater in the spinal cord is the dura mater in the brain has 2 layers. Has an outer periosteal layer, which is equivalent to the periosteum. Remember that, that's the surrounding bone tissue around the cranium, around the bones. The periosteal layer of the dura mater is like the periosteum. It continues, the intermeningeal layer is going to continue into the vertebral canal and form the dura mater around the spinal cord. These 2 layers are separated by dural sinuses, which collect blood circulating throughout the brain. There's no epidural space. So outer periosteal layer, which is essentially the periosteum of the cranial bones. The intermeningeal layer, And then the two layers are separated with these cavities within them that collect blood circulating through the brain. The dura mater with these two layers is going to form three major fissures and forms. It's going to form the false cerebri, which is going to extend into the longitudinal fissure dividing the two hemispheres. Right here. The tentorum cerebelli, which is going to separate the cerebral hemispheres from the cerebellum. And the false cerebri, which is going to separate the two halves of the cerebellum. I think of it this way: false cerebri is going to separate the two halves of the hemispheres, cerebral hemispheres. The false cerebelli is going to separate the two halves of the cerebellum. The tentorum cerebelli looks like a tent that sits on top of the cerebellum. That's the way that I remember. Meningitis is caused by an inflammation of the meninges. It can be caused by a bacterial or viral invasion of the central nervous system by way of the nose and throat. Pia mater and the arachnoid mater are the ones most often affected. Meningitis can cause swelling of the brain, enlargement of the ventricles, and hemorrhage. Most common signs are high fever, stiff neck, drowsiness, and intense headache.
No.
Blood supply to the brain. Blood supply to the brain represents only 2% of the total body weight. So the brain represents 2% of the total body weight, but it receives about 20% of the body's blood supply. The internal carotid arteries are going to supply blood to the anterior portion of the brain. The vertebral arteries are going to supply blood to the posterior part of the brain. If you remember, there was that little transverse foramina that went up the sides of the cervical vertebrae. Those foramina, those transverse foramina, are what the vertebral artery is going to move through. And you only see those foramina in the cervical vertebrae. So looking up, so here we've got this vertebral foramina coming up towards the back, vertebral artery, and then the internal carotid artery coming up towards the front. So here's the internal carotid artery. Here's the two vertebral arteries. The two vertebral arteries are going to merge to form the basilar artery, which is going to move over the top of the pons And we're going to have an anastomosis, a coming together of the vessels. Here's the posterior cerebral artery, so posterior, anterior. Posterior cerebral arteries. Posterior communicating arteries. Middle cerebral arteries. Anterior communicating arteries. And anterior cerebral arteries. Last part here, two different types of strokes. Hemorrhagic strokes occur when a weak blood vessel, an aneurysm, bursts. You don't die from an aneurysm. You die from when that aneurysm bursts, a hemorrhage. An ischemic or occlusive stroke occurs when the blood flow to the brain is blocked by a blood clot. Well, which one is worse? It depends on how much is affected. I saw a brain in from a cadaver that he'd gotten hit. It looked like he'd gotten hit and maybe went back and hit his head. And the result was that there was massive internal bleeding within the brain. And I am not someone who's really good with blood. And so when I first saw it, I kind of realized like, oh, okay, that's bad. But then I started really looking at it and I thought, that's just cool. Because it bled into both hemispheres. And what it does is it just destroys it. So one is going to lead to hypoxia. The other one is going to result in oxidation of multiple proteins, just destroying them. And you guys, that is that.
Thank you.
You're welcome.
Have a good night.
You
See you
too.
Wednesday.
See you Wednesday.
I have a quick question.
Go.
The circle of Willis, would you be able to go back over those real quick? I was trying to write them down as fast as I could, and
I don't know how much we don't really cover. Zena can tell you we don't cover it when we cover the brain, and we didn't cover it when we covered the blood vessels, which we go through in 122. And so the vertebral arteries right here.
Mhm.
Actually, do you mind? I'm going to do something different. I'm going to draw it out for you.
Okay. Hi, Ivy.
So vertebral arteries are going to come up through here. So they're coming up via the cervical vertebrae, coming up through the cervical vertebrae, and they're going to merge to form the basilar artery. They're going to merge to form the basilar artery. And coming off from the sides here, on both sides, are going to be the posterior cerebral arteries. So this is posterior. Okay, posterior. anterior up here. A and T supposedly. Moving up,
Cerebral artery.
say it again. I'll type them out. Give me 1 second, just to
Okay.
draw it out, and then I'll type it out. Coming up here, posterior communicating arteries. Middle cerebral arteries. And coming up here and supplying these, coming from down below, is the internal carotid arteries. And then coming up a little further, via these anterior communicating arteries, anterior cerebral arteries. Now let me type those out. So vertebral arteries down here. They're going to merge to form the basilar arteries. Well, these ones right here. These arteries right here and these arteries right here are both the posterior communicating arteries. Arteries. So it includes these two right here and these two right here. And it depends on what diagram you look at, whether it includes those or not. I say it includes them. These two right here are the posterior cerebral arteries. These two right here. These right here, coming off one here, right here, one right here, the middle cerebral arteries. What I try to remember is that I have two pairs of communicating arteries. I have three pairs of cerebral arteries. The posterior cerebral are coming off the posterior back. Middle cerebral are coming off the middle. And anterior cerebral are coming out the front. And they're all feeding the cerebellum, so I know they're all related. So don't make it too complicated. Try to simplify your life just a little bit here. Anterior cerebral arteries, and then right here, coming right here, and this one right here is the anterior communicating arteries. And this one right here, this one that's coming right here, is the other one. So the two major arteries that are supplying the brain are the vertebral arteries and the internal carotid. So this one right here and right here is the internal carotid arteries. So those are those right there. Of course it will let me put it right there. Oh, come on, there, okay. Does that help, Marissa?
Yes, thank you.
The one thing that the reason I even like to bring this up is this is the only place that I know of where you've got multiple branches coming off one circle of arteries. We have plexuses, we have anastomoses, but we don't have a circle like this anywhere else. We have ones that will move around a whole entire bone. Like Zena can tell you, we have arteries that are going to move around a whole entire bone, but we don't have multiple branches coming off that. And that's what makes it neat, is somehow in the evolution of humans, we evolved this thing, and you know, what would be the benefits here? What if you've got a clot somewhere? If you get a clot somewhere in this circle, the blood can flow the opposite direction. And you can minimize the damage. Guys, have a wonderful night.
I have one more quick question about due date.
Nope,
Sorry.
go for it. No, don't worry. I'm not going to leave until you guys leave. So go ahead.
I just want to make sure, so all of our chapter 12 is due by April 4th, I think it said online.
Okay. Yeah, that sounds.
Then you just said chapter 13 will be due next Sunday. So that's the 10th, I believe.
Is it? Okay.
Did you mean this Sunday or next Sunday?
You know what? Let's expand it out. I don't want
to make sure I write down the right dates.
Because bear with me, let me write down the dates just a second.
And Dina, I love your hair, by the way.
Thank you. This is my mommy hairdo. Wash it and leave it alone.
It's gorgeous.
Thank you.
So let's do this. There, I'm gonna shift gears real quick. Stop recording. I'm gonna actually just go to McGraw-Hill Connect right now. So I had it set up, and I don't want to make chapter 13 due on the same day that chapter 12 is. I think that's a lot.
Agreed.
Let's Yeah, and it even says chapter 14's due that same time. Let's make this stuff chapter 13. So chapter 12, that will be due on the 4th. Let's make the chapter 13 due on here, due on the 11th. But you know what, eventually it's going to pile up. If you notice that we finished one chapter and started another chapter tonight.
Mhm.
And you will find when we get to the autonomic nervous system, the autonomic nervous system will probably take us 2 hours to cover. The special senses will take us about 2 hours to cover. The muscle is going to take a lot more time. So ultimately it will pile up. Would you prefer it piled up now, or would you prefer it piled up at the end of the semester?
Wherever you think it's not the hardest.
I honestly, let's do this, because you're gonna find, I would prefer to have the special senses and the autonomic nervous system, have that stuff due on the same time. I'm trying to remember when your semester ends. When does our semester end?
May 11th, I think, right
That-
around there.
Last day of the semester?
Maybe it's sooner than that.
I feel like our finals and stuff are like before.
Like- Like the first week, right?
Yeah, I think maybe grades are due around 11 as well.
Let's see. Because I know I messed up the schedule because I didn't realize we were off for the whole week of spring break.
Yeah, you're right, Christina, because I know one of my finals is the first week of May.
I'm going out of town to my sister's house, and thankfully it's like right after we get done.
So the last day of class is May 2nd. And we have it set up so that we would do the autonomic nervous system and the special senses on 2 separate days. But I will tell you, it's not going to take a full day. Neither of those will take a full day.
And so I see right there, our final exam is on May 5th.
But you know what, your final, because this is an online class, I'm going to give you more than one day to take a final. I'm going to give you a couple of days. It might be up to a week. I haven't gotten to that point yet in my thought processes this semester. But I'm going to give you at least a couple of days.
Okay.
But let's have it so everything I'm trying to remember when my grades have to be into for hack, and I can't remember. I think it's like probably around May 11th. So everything has to be done by May 11th. Let's set,
That's not too far away.
I know, it's pretty amazing how quickly it's jumping up on us.
Mm-hmm.
Let's have how much time does it take you guys to do the smart book assignments?
Well, you read it before.
What?
Then it depends for me on like how well I read and kind of digest the information beforehand. So
Yeah.
On average, how long do you think it takes you?
More than an hour, I would say.
Okay. I think they're set up. Let me give you an example. So the smart book assignment for chapter 7, if you were to know all the answers, it is set up. Bear with me here, edit assignment. Okay, maybe it's not gonna let me get it. Oh, well, that wasn't very helpful. Just a sec. Let me do one that's maybe hasn't been done yet. Chapter 15. It is set up so that it should take you 54 to, it should take you anywhere between an hour to an hour and a half.
That
On
sounds about
average,
right.
how long does it take you?
It takes me a while. It takes, like, I get distracted between, like, if I get like one thing wrong, I will go onto like reading to see like why I got it wrong, or I don't know. And then before I know it, I'm like on something else. So it takes me
Yeah.
a while. Like, I don't know, it takes me like 3 hours to complete the whole thing.
Hey, let's, gonna take my minion. Yeah. Love you, Mom. Let's, how many of you have actually done the stuff for chapter 12 already?
I did it a long time ago because I thought it was due a long time ago.
Because we kept pushing it back. Let's, but the other thing is I could split it up, but it wouldn't, so that things wouldn't be just due on Monday.
Yeah, that's what I was just gonna say, even if it's just not due on the same day.
Okay. Students don't like that. Some students get really mad when professors don't change around due dates. That's why we try to keep them consistent.
Well, I'm grateful you're flexible then.
Okay. Why don't we do this? Let's make this one. So this is chapter 13. Let's make it due on the 8th. So next Friday.
Okay.
And that will be the smart book and the quiz.
All right, sounds good. Thank you.
Okay. And then the 14, I don't know if we will finish it next week. It's, if you saw, it's a much longer PowerPoint. We made a lot of headway tonight. And depending on what goes on, excuse me, depending on what goes on Wednesday, we could go forward with lecture, but I do want to do a dissection with you guys. And the reason is because I think a lot of online professors don't do dissections. And listening to some of my students in 122, you remember, Zena, when I was asking about it last week, how many of them actually saw like the eyeball or saw a brain or anything? And the professors didn't do any dissections. And so because of what Ivy wanted, because of what Ivy wanted. I have some students in 122 who want to join in with us on that night that we do that because they've never seen it. So Ivy, it was a good idea. Let's right now, let's just have it set up so that it'll be the 8th, the 13th, and then let's see, we can make this do the 11th. Yeah, let's do that. Let's have chapter 14 due on the 11th.
Okay. The smart book and the quiz.
Yes. I think usually, do they help you study for the quizzes a little bit? Maybe. Maybe not. Okay.
Yeah.
Oh, so are they both gonna be due the 11th or
Yeah,
did I
let's-
misunderstood it?
Let's make them both due on the 11th.
I mean, the 13, is that supposed to be?
No,
due
it's
on
gonna
the
be
11th
due on
or
the
1st?
8th. It's gonna
The
be due
8th,
on the 8th.
Okay. Gotcha.
Or do we want to make it due on the 10th? The 11th best?
Yeah.
Okay, let's do it the 11th.
Because then we'll have some labs in between there as well, right?
Right, right. And I guess the special census is already available for you. I didn't realize it was already available to you. And of
Okay.
course, that's, I can't remember how many labs ahead that is, but it's already available because I put it together this weekend. I didn't realize I had it open. Where were we, Mary? Okay, there it is. Edit assignment. Yeah. Okay, are there other questions?
And that was for the special senses is exercise 24. Mine doesn't show.
It doesn't show you, so it's only available for some people?
I think you last week class only opened it for her because she had requested it.
But I could,
It might open for me too, though, because I saw there was a
imagine I did,
and then a bunch of PowerPoint.
I
Let
can't
me see if
imagine
mine opens.
I can't imagine I did that because I only made it on Saturday.
Oh, okay.
It was like a really late Saturday night project for me.
Yeah, mine goes in, when I click on it, it does go to open assignment. So it must be then. It just looks a little different this time.
Okay. It might be easier to do
It
it.
doesn't
once
show me
I-
a due date or anything.
It might be easier to do it once I put together the PowerPoint for it. But you could start it if you wanted.
That's why it looks different. That's not there.
I figured out,
Alright.
I made some moves in my preparation wise. I figured out how to speed up my time. My putting together Zena's class right now, the 122, is my busiest thing I've done in a long time because I have never taught that class. And so I'm preparing a lot of things by, I sometimes will be up, it's an all-day Friday class. And I will get things posted around 3 in the morning and then be up for class the next morning. And I finally figured out, I taught the second part of A&P over the summer at Carroll Community College, almost 3 years ago. And I don't remember a whole lot about it. It was my first time teaching, and it was a next to impossible task because if you think it's hard to prepare a class during the semester, it's a lot harder during the summer because you're teaching 16 hours a day, 16 hours a week instead of just 6 hours. And so I could not remember a lot of what I covered over that time. couldn't remember the subjects, I couldn't remember a lot. Well, I started going through the PowerPoints and realized, wait, these aren't so bad. And so I'm right now going to change the way I'm doing the 122 prep and start preparing it using those a little bit. And that will speed up how much I get done for you guys too. And so let me see if I can get those special census up this weekend.
I have a
Go
question.
ahead.
Are we gonna have any labs due? Only because I'm still planning. 'Cause I have
No labs due this week.
but I'm working ahead.
Okay.
I won't be able to be on the computer screen because I'm having surgery on my eyes.
Wow. Yeah, I remember you saying this. Okay.
So I just want to make sure I'm still ahead and not behind. So for those 4 days, I won't be able to do any work from the 7th to the 10th. So I will work ahead with lecture, but I just wasn't sure if any lab was gonna be added in there between that time.
What lab is it? Let me look at the syllabus. So it would be it's going to be the brain and the cranial nerves is what we would do on Thursday. We're not going to do the autonomic nervous system. So it will be the special senses.
Okay.
Jennifer, can you give me until Wednesday night and I'll have those open for you and you can do them.
Oh, yeah. Sorry, I was in the wrong week. I was like Wednesday night, the 6th. No, that's the 30th. Absolutely. Yes, that's fine.
Yeah, I haven't even, I'm adjusting them. I'm making them so they're not as difficult as they were for students last semester. And so, yeah, give me until Wednesday night and I'll have,
Sorry.
we're not going to do this autonomic nervous system. We're just going to do the brain structure and function and the special senses.
Okay.
And I'm going to give you credit for this one right here.
Okay.
So that'll be lab 20, 21, and 24, correct? Okay.
Yes.
Okay.
All right.
Okay. Yeah, I might just do it right now as soon as we're done here.
Okay. Thank you.
You're welcome. I'll actually, Jennifer, I'll open them all tonight. And you'll just know that they're there. Because if I get started while I'm still sitting here, I'll get it done. And then it'll be done and I won't have to worry about it either. Any other questions or issues?
No, I don't think so. Thank you.
You guys have a wonderful night, okay?
You too.
Ivy, have a good night.
You
You're
too.
really quite cute.
Thank you.
I do have a question, so I'll wait until everyone is done though.
Thank you.
Bye.
Hi. What's up, Zena?
I just have them written down here.